I am going to talk about our protocol for the endovascular management of cerebral vasospasm. In our institution, the patient is brought to a hybrid endovascular operating room. They are laid supine on the angiography table. All patients undergoing endovascular intervention are placed under general endotracheal tube anesthesia. Often we work in parallel with anesthesia. For example, we obtain femoral artery access while they are intubating the patient. The patient's head is held firm in a U-shaped pillow and taped in place to minimize movement during the procedure. The ventriculostomy tubing is taped to the side of the U-shaped pillow to prevent contact with the angiography biplane. A contrast injector and multiple pressurized heparin saline bags are prepared. Endovascular equipment is placed at the foot of the table, and a second table is moved in place behind the endovascular surgeon for equipment preparation and overflow capacity. The lines are meticulously cleared of any bubbles. On the second table, we have a 4 French micropuncture access kit, an 11 blade to make a small access incision, a 6 French sheath, and a syringe of lidocaine, bupivacaine, and bicarb. In the middle, we have a bowl for our wires and sterile towels. To the right, we have gowns, gloves, contrast, and heparinized saline. A 4 French micropuncture kit is used to access the femoral artery. Unless there is pre-existing vascular disease, the right femoral artery is typically chosen. Balloon angioplasty has been shown to increase lumen caliper, improve cerebral blood flow, and reduce the incidence of delayed cerebral ischemia. Due to the risk of vessel rupture, we reserve the use of balloon angioplasty for larger proximal arteries. A cadence syringe is used to inflate the balloon since the syringe provides a very precise measurement of volume introduced into the balloon. In order to ensure visibility of the balloon during the procedure, we first test the balloon with inflation outside of the body and place it under fluoroscopy to evaluate contrast opacity. Verapamil is an L-type calcium channel blocker. We use verapamil since the drug has a well-known safety profile established in the cardiac literature for the treatment of coronary vasospasm. The verapamil is diluted in heparinized saline to a concentration of 0.5 mg per cc. Our typical dose of verapamil per vascular territory is 20 mg, with a range on the order of 10 mg to 40 mg. Our choice between angioplasty and verapamil is determined by the vascular territory affected by vasospasm. Vasospasm that is exclusively distal is treated by verapamil. Vasospasm that is proximal is typically treated first by verapamil and then by balloon angioplasty if needed. Proximal and distal vasospasm also requires a combination of both modalities. This is a left internal carotid artery angiogram performed shortly after the time of a patient's presentation with a subarachnoid hemorrhage. This angiogram is considered the patient's baseline study. Note the normal caliper and configuration of the vasculature. The caliper of the vasculature in future angiograms will be compared against this baseline. This is a repeat left internal carotid artery angiogram of the same patient. The patient had developed a neurological change refractory to medical management. Note the severe proximal and distal vasculature vasospasm as indicated by the blue arrows. This is an unsubtracted view showing our compliant balloon in the left middle cerebral artery. The 2 blue arrows indicate the proximal and distal radiopaque markers of the balloon itself. Also note the coil mass of a previously treated aneurysm. Our target vessels for balloon angioplasty are the internal carotid, M1 segment of the middle cerebral artery, and basilar artery. Rarely do we target the A1 segment of the anterior cerebral artery or P1 segment of the posterior cerebral artery because, in our opinion, risk of balloon angioplasty in these territories is higher. This is a left internal carotid artery angiogram performed after balloon angioplasty of the proximal middle cerebral artery and distal internal carotid artery. Note the improvement in the caliper of both vessels. There was no attempt to treat the anterior cerebral artery given the small caliper of the vessel. This is a right internal carotid artery angiogram performed shortly after the time of a patient's presentation with a subarachnoid hemorrhage. This angiogram is considered to be the patient's baseline study. Note the anterior communicating artery aneurysm, which was subsequently embolized. Note the normal caliper and configuration of the remaining vasculature. This is a repeat right internal carotid artery angiogram of the patient performed at day 7 after a subarachnoid hemorrhage. The patient had developed a neurological change refractory to medical management. Note the severe proximal and distal vasculature vasospasm. This is a right internal carotid artery angiogram performed after infusion of verapamil. The verapamil was used both to treat the distal vasospasm and facilitate balloon catheterization of the proximal vasculature. Note the modest increase in the caliper of the vasculature. This is a right internal carotid artery angiogram performed after balloon angioplasty of the right middle cerebral artery and distal internal carotid artery. Note the further increase in the caliper of the vasculature. It is critical to have a clear understanding of pre-vasospasm vessel diameter and anatomy. Side-by-side comparisons with the vasospastic anatomy are often helpful. Knowledge of the prior anatomy will assist with choosing angioplasty or an intraarterial vasodilator and avoiding overdilation and vessel rupture. As a general rule, we do not balloon angioplasty any vessel smaller than 1.5 millimeters. When the vasospasm is very severe, intraarterial vasodilators will facilitate the catheterization of the vessel and allow for subsequent balloon angioplasty. Avoid overinflation with balloon angioplasty at all costs. Attempting to balloon dilate to achieve a normal angiographic appearance may result in a higher risk of vessel rupture. Recurrent vasospasm is very high with the use of intraarterial vasodilators alone. Multiple rounds of vasospasm treatment can occur, but eventually result in good clinical outcomes.